Physical therapists, if you're not up on blood flow restriction training, you're missing out. BFR, it's the future of rehab. Owens Recovery Science has the certification for learning BFR from the ground up. You'll get hands-on with the best tech, expert insights, and tools to deliver real results for your patients. Stop waiting. Check out owensrecoveryscience.com. That is owensrecoveryscience.com and get certified in BFR today. Physical therapists, if you're ready to stop playing small and actually master your specialty, Brooks Institute of Higher Learning is where it's at. Imagine one-on-one mentoring, hands-on labs, top-tier facility, all while earning a full salary and benefits at Brooks Rehabilitation. We're talking 8 cutting-edge residencies, specialized fellowships, and a 93% board pass rate for graduates. Get trained by the best with the best. Check out brooksihl.org. That's brooksihl.org and start leveling up your career today. How we doing? PT Breakfast Club live. A few minutes. A few minutes. A little bit late. I'm getting some microphone issues here. Hang on. There we go. MacBook speakers. There we are. All right. Now I can hear you guys without the headphones. Good morning. I'm a little bit bundled up. We've actually felt winter or fall for the first time here in upstate New York. What about you guys?
Yeah, we've got flurries coming down behind me. I
don't like it.
We hit winter finally. Dave?
All's well here. I think Jimmy, you guys used to give me crap about lighting and audio, and I think I need to send Jimmy a ring light desktop camera or something because it looks like he's in detention or something.
Yeah, so building the studio. I have 2 lights, so I've got good lighting, but one of them died this morning. So one of them is actually like, if I can rotate the camera, like one of them is just like out and won't turn on. So I'm like, awesome.
Here it is.
So it looks like I told people yesterday, it's like a proof of life video. It looked like I'm in like a basement somewhere.
For sure. You got the uncovered outlet behind you, the block wall.
So I was having a buddy too. Like, this is also like a great cheat code, which is I could go online and watch 50 YouTube videos about key lights and other lights and light one and yada, yada. And I've done that. And then I was just, I know a guy who makes really, really, really great videos. Let me just pick his brain and jump on a Zoom with him. And I walked around with my phone. He's like, oh yeah, get your camera like 7 feet away from the wall when you're shooting, because you need depth. And then we're going to put a key light there. And I'm like, good, writing this. I'm like, I don't know what a key light is. Remember, I'm from radio. I have no idea. So we're figuring this out. So the answer is usually people. The cheat code is usually people, YouTube or people in person.
So let's bring Julia on.
Yeah, we're gonna bring Julia on. How do we give her a setup? You know what? Let's have her do the setup. Julia Laurent. Julia, welcome to the live stream. We haven't done a lot of guests. I want to do more guests, but kudos on you for jumping in, and a couple of yahoos that slid into your DM on LinkedIn and said, yeah, okay, I'll do your weird live stream. So Julia, what's your superhero backstory?
Yeah, absolutely. So I actually have a pretty cool superhero backstory. I used to be a professional figure skater and skated on Team USA for 6 years. Competed internationally, retired at the ripe old age of 18, and then went to PT school. So here we are.
And was it an injury that are you the cliche of injury to a physical therapist?
Ironically, no. I was just tall. I'm 5'4", and that's really tall for a figure skater. So here we are.
5'4" is tall for a figure skater?
Yep.
Really? Okay. Perfect. And then where are you now geographically?
I am in California, Southern California. So it is a wonderful 5:34 a.m. here.
Yeah, you're coming to us from the left coast. And then, okay, so what was your superhero story in the profession of physical therapy? Where'd you go to PT school again? I know I saw it on my LinkedIn page.
Yeah, Florida International University.
Hey, I went to FIU. I'm an FIU grad.
Yeah.
Yeah.
And then where's your career taken you, which is like sort of the reason we bring you in. Like, your career's taken you, like being a professional figure skater, your career's taken you in some pretty interesting directions.
It has. And as most PTs started out in outpatient ortho, because we all graduate school and think that, that's the latest and greatest and that's where we land. did outpatient ortho for a couple of years, then transitioned into workers' comp for a couple of years, and then realized that working 9 to 5 wasn't my jam, and transitioned into digital health because working from home is way cooler.
Working from home is cooler. You get to stand in your basement and do a live stream every once in a while, like me.
Exactly.
So that's sort of one of the part of the reasons we bring you in today in terms of like digital health. I feel like that's like digital media. Like digital health can mean so many different things, right? It's just like sort of a combination of two different words. Take us into your day-to-day experience. I mean, you worked particularly with Sword Health, to be specific. What was it like working in a digital physical therapy setting, which sounds like those two phrases, some people think they're in opposition. What was it like working in that setting? How patient responds to this, sort of new, mode of care? Like, give us what's the tea?
Yeah, no, it was really neat. And honestly, when I was like transitioning out of the clinic, my main goal was just to work from home. I didn't really know what that would look like. I didn't know what to expect. And, got the really cool opportunity, got hired on at Sword Health as a PT. And, starting off, it was a startup. And so there was no real kind of training or anything like that. They were like, all right, here's a platform, have fun with it. Here's some patients and make it work. And honestly, that was the really cool part because we kind of developed our own processes, developed our own way of treating online. And the way that, we functioned is it wasn't necessarily like telehealth, like a lot of people think. Like there wasn't Zoom conversations. We didn't physically see patients doing exercises. We really just used the technology. The patients did their exercises on their own time, which was great for them. They loved that. I had patients doing exercises at 5 a.m., 11 p.m., whenever they so chose. And then I would get feedback based on how they did their exercises on my time, which was also fantastic for me. And that model was really neat where, there was no limitations. It wasn't like you had to make an appointment for 8:30, miss work, and, drive half an hour, sit in traffic, and then do the same thing in reverse. So I think that's where, digital therapy is really great and really amazing. And there are just so many benefits to that, just from a movement standpoint, right? We all know just even moving, even if it's not right movement, even if it's not, a specific exercise, it's just getting people to move is huge.
Yeah. What about difficulties? Like, what were the friction points or like the things? I mean, you said you're making this up as you went along in a good way. What were some of the things you guys were like, hey, this is hard?
Yeah, it's difficult because obviously you're not seeing the patients do exercises. So as much as we know that movement is great, sometimes we don't know if they're doing it right. We don't know if, how well they're moving. The feedback that you get sometimes isn't great. And technology is developing. It's developing by the minute, right? And, sometimes it's not quite there yet. And I think that's where we've kind of landed in this space at this point, is the technology is starting to develop, but it's not 100% there. And so there would be a lot of kind of tech concerns of, I'm lifting my arm, but the technology is not seeing it and things like that. So I think that's where the main friction points were.
Yeah. All right. So outside of just technology limitations, my last question for you is, so given this experience, what do you think needs to change or evolve for digital physical therapy to actually reach its full potential? How would you, as someone who's done it, make it better? Where do you see the future of this going? What's 6 months, 6 years from now look like or feel like?
Yeah, it's a really cool question. I actually spent a lot of time kind of thinking of how would I make this better? Like if I ran my own company, what would I do and how would I make it work? And I think that it can go in so many different directions based on the patient population, right? Are we going to be able to treat everybody virtually? Absolutely not. As therapists, we know we still need hands. We still need that hands-on component for a lot of people. Range of motion isn't just going to happen because I said so. But there's so many populations where, they can do things on their own. They don't have to walk into a clinic. We don't have to, count 3 sets of 10 for them and, just sit there writing our notes. And so I think in the future, having platforms based on populations, having platforms specific to specific things. So really just, post-op patients have their own platform and have their own space. That's where I think a lot of the kind of future can lie. Right now, it's so general that, you know, we were treating fingers and necks and backs and ankles and hips and knees and people that could barely move and athletes. And it was just, it's so spread out. And making it a little bit more specialized in that sense, I think can be really powerful.
Dave, what do you got?
That's awesome. Julia, in regards to any patient feedback, patient or client feedback, and I don't know, since it was a startup, I don't know if they shared this with you or if you had any text, email, or any communication with these members, patients, clients, whatever we're going to call them. I don't know. You can correct me on that. Any constructive feedback from them, like maybe some percentage of the folks, they get the login, they touch base with you or someone else on the team, and they give you feedback like they don't like it. Us tech things aside, like not Wi-Fi issues, not laptop issues, whatever, but someone that comes in and is like, oh, like I'm not a fan of this, or I had in-person physical therapy before and this doesn't seem, I don't know, good enough. That's my bias. That's my question to you, is like any, you know, constructive feedback from the patient member side.
Yeah, absolutely. And we would talk to the patients every single day. I had chat threads with everyone that I treated. And I think the nice thing and the negative at this point in time is that there are still a lot of people that haven't had PT experience. And those are the people that really benefited the most because they didn't come in with those expectations. People that had therapy in person before, maybe they were like, well, where's my hands-on? Like a lot of people are used to their stim and their ice and their heat and all of the other modality things that we, you know, like to throw at people that they don't have in this virtual world. And I think that's where the education really comes in, is that, yes, those things are great. You can do those on your own, but the movement side is really where we're going to see the benefit, both in person and virtually, right? And so I think that was the biggest complaint is, yeah, movement's great, but it's also boring. It's also painful sometimes. I don't really want to do it, where I used to go into a clinic and just lay there on my back with a little bit of tinglies and some heat, and I felt better.
Yeah.
So I'm curious real quick, from a fulfillment perspective, you know, as a therapist, as a clinician, you were in PT school, you had a certain preconceived notion of what you were going to be doing. Most of us say, well, we want to help people. How did you find fulfillment in what you were doing? You know, what was the most like fun or enjoyable part of that kind of career compared to maybe a therapist who's in the clinic, who maybe sees fewer people? And I don't know what kind of volume of caseload you were doing, but talk to me a little bit about the fulfillment side of it for you personally as a clinician.
Absolutely. And I think that's huge. I'm one of those really weird data people that I track data on pretty much everything. And so prior to going digital, I had a spreadsheet on my laptop of how many exact visits I had seen in my career as a PT. And I think it was something like 10,100, something like that. And going into the digital space where, I mean, we had 200 to start with, then 300, then 400, then 500 patients, you know, on our roster at any given time. That to me was really neat because I was touching so many more people, you know, every single day, where in a clinic, you know, when you see 20 patients a day, that's already like super overwhelming. So I think that's where I got my fulfillment. Not everybody got that, right? And it's not for everybody, where you're like, well, I'm not giving that personal touch. I'm not, you know, specifically touching these specific individuals. But to me, if I can get 500 people to do 10 squats a day, then that's the fulfillment that I wanted for myself. And that was the help that I was giving. Am I necessarily fully treating back pain, knee pain, hip pain? Maybe not, but I'm getting people to move.
Okay. And so you're looking for do you want to stay in this vertical? I mean, I know you know, at the top of the show, we were talking about how, you know, you're looking for something now that you've left. What's next for you personally?
Yeah, absolutely. So ironically enough, I did get laid off on the same exact day that I finished my MBA. So, you know, it was a great day. It was a weird Friday. So I think for me next is really moving into the operational sphere. I've been in operations, even at Sword Health. I developed their on-call platform, kind of did both jobs. I was a PT and operations. So really transitioning more into the operational sphere and, you know, using what I know now as a PT, as a clinician, to kind of develop the next best thing. And you know, not let someone that's not clinical, that doesn't know the healthcare as much as,
Right.
you know, we all do, take over. So that's where we go.
Julia, good luck. Thanks for
Thank
giving
you.
us a little insight from someone who's done it. People like, you know, me, I just sort of like guess. I'm like, I don't know, it looks like this, but having you give it some color is much appreciated. So thank you for doing that.
Absolutely. Anytime.
You can go back to bed for a few hours now.
I think I will.
All right.
Thank you so much,
Thanks, Julia.
See you.
Thanks.
Awesome. It's good to have guests. I thought we'd have more. I thought we'd have more guests. Maybe we should. I don't know. Like that was, 10 minutes or a hot 13 minutes, right?
Yeah, I don't think people know it's an option. I was just talking to somebody yesterday. I was like, you should call in. We used to do the call in.
Yeah, well, now I've got the setup. I can do just phones if they want to do just that. If they don't want to do video.
So
I'm trying to bring up my LinkedIn poll.
Yeah, I wanted to talk about that. What else we should be doing or considering from an educational perspective? When you got it up, let us know. I said marketing and communication. Like, to Julia's point, I think the whole experience of digital health, virtual health, synchronous, asynchronous, everything pivots on your ability to communicate. Can you communicate empathy, compassion? Can you communicate expertise? Can you communicate all of these things through your voice, through your image on video?
So there's the poll we have if you're watching a live stream. Yesterday, I think I said, I made the bold statement, right? You aren't going to get ahead in 2025. If you're going to get ahead in 2025, you need to do the things most others aren't. And then maybe I could ask better questions too, because I said, what's the most valuable degree a physical therapist can add in 2025? And then some of the things aren't degrees. Like, so I literally asked for a degree question. Then I said like clinical certifications. I should have said just what's the thing you can add to your DPT degree. But the 4 options I gave were an MBA, which has about a third of the answers right now. Clinical certification, OCS, GCS, PCS, SCS, telehealth certification, which has 5%. And even people in the comments were like, that's a certification. And I'm like, you knew it was going to be a certification. Like 10 minutes after it became a thing, someone's scrambling to figure out how to do it. And then what sort of shocked me, or the one thing that made my eyebrows go up, were about a third of the responses are other. But I asked people like, what's the other? No one's really answering. Everybody's just saying, I don't know. It's not an MBA. It's not a clinical cert. It's something else. What? I don't really know. Something. I don't know what it is. It's in the aura. But look what Julia just did. Like, she literally gets laid off from Sword Health the day she finishes that first choice there on the list, which is an MBA. Is this a bad sign though? Because a third of those people are saying I'm getting an MBA. Why do you think they're getting that, Dave? Is it to be their own boss, or is it to go into administration within these organizations? So are we still doing a bad job of making that first job being a PT so unenticing? Everyone's just looking to get out and up.
The MBA most likely is to excel higher up in some other organization. If you're going to start your own practice, like, it makes basically no sense to go and get an MBA. So for Julia, like, if she wants to, have some operations level, like COO type level, or, I don't know, senior vice president of operations, clinical operations, whatever, like, then, maybe it makes sense. But I commented on that, and I think that the clinical things are table stakes, right? So that's what I commented. I tagged both of you on this post.
Yep. I
said, if you don't have the clinical skills, if you can't, like, whoever your ideal population is, right? Like, is it geriatrics? Is it sports medicine and athletes? Is it like workers' comp? I don't know, whatever it is. I don't know, whatever your ideal population is. If you don't have the differential diagnosis skills, if you don't have the clinical skills to, I don't know, maybe, I think I said 80%, but 70, 80% of the population that walks in, if you don't have the differential diagnosis skills, the ability to improve someone's situation in the first visit for a lot of these normal conditions, you need you need more clinical skills. It might not even be a cert though. It might not be one of the SCS, OCS, whatever. It could be, I said a cert through ICE, Jeff Moore's Institute of Clinical Excellence. Like, those are certs that they have different tracks for geriatrics, for pelvic floor, pelvic health, all that type of stuff. So if you don't have that, you should. you should absolutely go get that. But I clicked other because I think these clinical components are table stakes after your first 2-3 years working in the profession.
And Tony, you said communications, which of course, obviously is going to, resonate with me. I don't think you need to go get a degree in communications.
No.
I remember talking, but you definitely should hone your skills, and you can do that a billion different ways.
Yeah, I half read the post. I didn't see that it said degree. I was just saying, what else should we add?
Yeah.
And so, but even within that, listening to Julia talk, one of the things that I always think about is, are there generational differences here in what, the three of us are generally in the same generation. I think Dave's probably the younger out of the three. But within that, when we were at PPS up in DC, I talked to some other clinicians, therapists that I had worked with in the past, and they all kind of said the same thing. They were like, a lot of the newer generation, now this is a generalization, they don't have the same impact on their patients. Their patients don't kind of, air quotes, fall in love with them on that first visit. They don't seem to get the same kind of response that we used to get. But I don't know, is it because that generation of therapists is looking to achieve different things? And so from a metric perspective, they're getting the outcome that they want, but maybe not the same connection that we all did as young clinicians growing up. I don't know. I don't know how you make those judgment calls on a generational basis, but I agree with Dave. Yeah, you basically need to impress upon your patient, look, this is important. I'm the expert. I'm going to get you that first win. I remember talking to Jerry Durham early, like in social media. And one of the main things we talked about was, my top priority, day number one, is letting that patient leave in a successful way. Meaning, I'm not going to challenge them. I'm not going to do special tests that make them fail in an effort to show them how deficient they are. They already failed with their primary care. They failed with their ortho. They failed with everybody else. They're coming in here. They're going to leave a success. They're going to have an easy win that's going to make them feel good. And they're going to leave before they want to leave, so that they want to come back. That is my top priority.
Yeah.
And so, I don't know. Is that something you learn? Is that something you're born with? How do you figure that stuff out? What do you guys think?
I think it's something you have to, I think it might be something, if someone was going to agree with Tony, which I do, I think it's something you have to unlearn from PT school, not in a bad way, but PT school says, go in there and do the PT things. Like, what's the first thing you do? It would be the opposite of what Tony said, which is like, well, special tests, because it's a shoulder. I'm going to do all those things. Again, I'm still sitting on this idea. I even have the title of a course I want to pitch to PT schools, which is, hey, why are these soft skills so damn hard? Which is, it's not that those things, psychology and communications, and what is the goal of the first treatment? The goal of the first treatment is to get them there to the second treatment, right? Do you think you're going to make monumental change in one treatment? And maybe some people will push back on me and go, I have magic fingers. But I think it's really like expectation setting, realistic expectation setting, and being able to read and recognize, because some people want to dig right in and some people don't. But why are those soft skills so damn hard? Because they're things you develop over reps. Yeah, there's some basics you can teach, but a lot of it is figure it out, and you've got to do repetitions on that.
I still want to debrief a little bit more with Julia's conversation, but with the soft skills, do you guys think that there's some component of the younger therapists that are newer grads and they've come up with, like, they've only known technology and tablets and social media? And I mean, you go to a restaurant and a ton of families, parents throwing phones and iPads right in front of their kids to shut them up. And yeah, I mean, it's wild. Like, people, now that, like, our son is 7 months old, like, I'm legitimately thinking, like, maybe when he's I don't know, 7, 10, whatever years old, like, getting like an analog getting an analog flip phone for texts and phone calls, but not the whole internet, not all the apps and games and things like that. Do you think the new grads are affected by social media, technology, tablets, devices?
1000%. There's no way you couldn't. It's not a little change. This wasn't going from like 5 TV channels to 55 TV channels. This was like, we can't even wrap our heads around what it's like to grow up right now. I mean, I've got friends with kids that are 8 to 18, and they're looking at me like, what do you mean a phone? Ask someone under the age of 25 why we call it hang up the phone. They have no idea because they haven't hung a phone on a wall. They don't understand why that is. There's no satisfaction in hanging up with a finger and
slamming the phone.
Slam that phone down and be like, yeah. My favorite line when you're going to hang up on someone was like, hey, man, tell me if my dial tone's working properly. When they're like, what? Click, right? But they don't understand that because there's no dial tone anymore. So 1,000%, there's no way you can separate the nature part of nature versus nurture.
Yeah. Now, Sammy said, what about post-COVID PT generation, different approach, new grads, didn't have much personal one-on-one. I agree. Now to cite Gary V, he had said years ago, he was like, look, parents are getting obsessed with, kids on phones and devices and iPad kids and all this stuff, which I agree. Like, we limited access to phones and all that stuff when our kids were younger. But we also acknowledge, look, this is the way people communicate in the current landscape. We need to let our kids figure out what's going to happen when I get on Snapchat, on Instagram. How do I communicate? How do I text? How do I manage social media? So we started letting our kids get in 7th grade, definitely by 8th grade. We're like, look, we're going to give you a longer leash. I don't know. I think none of us actually know what this is going to mean, because my grandparents' generation complained about my generation in the same way my generation's complaining about future generations. So it might just be part of life, and this is, what we live in. But like Gary V said, I do think we have to understand different modes of communication, and how we work in those different modes is going to be so impactful to our businesses moving forward, but also to our personal relationships. Yeah. So Dave, what else were you thinking about that conversation?
Yeah. So with Julia, I mean, she's talking about having, I don't know, hundreds of patients, members, whatever, customers on her census or roster or whatever. I mean, we had like a concise, amount of questions, and we wanted to kind of get back to the rest of the episode. But my question to you guys would be, why, like, to do the things that she's doing, do you need to be a licensed physical therapist to do that? Couldn't I just get like virtual assistants? I can, train virtual assistants in another country and kind of do those same types of things. We could undercut Sword Health and Hinge Health. We could call it Bitter Health. We could call it Revenge Health. We can undercut them, and we can make it even cheaper for them. And we can have Dagger.
Shorter than a sword, cheaper than a
Dagger
sword.
Health. Dagger. It doesn't sound negative at all. And we can undercut them with cheaper labor, because what she was describing, and guys, please correct me if I'm wrong, Julie, in the comments, LinkedIn, whatever, correct me if I'm wrong, but you have hundreds of patients. She said she doesn't even see them do their exercise. I mean, like, couldn't just anyone do this? Couldn't we just have personal trainers do this? Couldn't you have someone in, the Philippines, India, some other country do these types of things?
Tony says no.
No, I talked about this last night in my Zero to Paid course. Like, this is the perfect example of saying, what are the actual skills of a therapist? What requires the skills of a therapist? The therapist does not need to watch you do 10 repetitions, 3 sets of seated lat pull. Like, that can be delegated out. A robot, a machine, can watch you do that and analyze your movement. A therapist does not have to do that. What the therapist does is manage the case. The therapist oversees, and then when there's a problem, now the therapist gets more involved. Now we get more granular, and we go into it deeper. Go ahead.
In your office, when you guys bill in-network insurances, are they paying you to manage the case, Tony, or are they paying you for therapeutic exercise, the 10 squats that she was talking about?
So I would tell you, and I'm going to pull a screenshot up. You guys keep talking. I'll pull a screenshot up. Medicare has a list of 7 things that they consider rehabilitative therapy by definition. It's evaluation. The physical therapy evaluation, that is done by a physical therapist. You can't delegate that out to a massage therapist. Developing the plan of care, establishing goals specific to the patient's physical limitation, monitoring and assessing at regular intervals, not every single session, assessing at intervals, prescribing home exercise or equipment for home to augment function, and training or teaching the patient and the caregiver what to do at home. That is what Medicare says. Nowhere in the guideline does it say manual therapy, therapeutic exercise, doing the actual treatment. I believe third-party payers, yes, that's what they want us to do. They want us to evaluate, to develop the plan, to delegate out that plan and oversee, not sit there for an hour actually treating the patient. That could be delegated to a personal trainer, to a robot, to AI, to anything else. Dave?
I mean, on visit number 2, visit number 3, visit number 4, you're billing Medicare for therapeutic exercise or whatever, therapeutic intervention, neuromuscular reeducation. Isn't that those are billable units? I understand your argument on the assessment side, the evaluation side. I get that. And then on, the 10th visit or whatever the interval is for reassessment and progress notes. I get that.
Tony's going to pull that image up.
So I just shared last night, Jimmy, if you want to look, or I'm looking at it while I talk. I just shared last night a quote right out of Medicare that basically said, look, once you've evaluated and assessed a patient, once you've shown them what to do, therapeutic exercise is no longer a covered service. You're done. Right here, I know you guys can't see it, but I'll just read it. Many therapeutic exercises may require the unique skills of a therapist to evaluate the patient, design the program, instruct the patient or caregiver in safe completion of the special technique. However, after the teaching has been successfully completed, repetition of the exercise and monitoring, it says, and monitoring for the completion of the task in the absence of additional skilled care, we'll talk about that, is not covered, period. So what do most of us do? The reality, most of us are billing inappropriately. I fully agree. Most of us are billing inappropriately based on the published guidelines. I would also say the ones that make it appropriate, I'm showing air quotes again, I can sit there and helicopter around the patient. I could be like, you got to do this and you got to do that. And let's talk about this and let's talk about that. The reality is the patient just needs to do the work. This is the bike. This is the pedal. This is how you make it go around. Now for the next 6 weeks, make the pedals go around faster for longer periods of time. You are going to get just as much benefit from getting the patient to do that without charging Medicare as you would from me sitting there and micromanaging every little nuance of it. Now, does the patient enjoy it? No. Is the patient going to do it? No. But Medicare tells us also in the guidelines, they're not paying us to motivate the patient. They're not paying us to make it more exciting. They're not paying us to make it fun or make the patient do it. They're paying us to show the patient what to do based on the evaluation that we've completed. I just think that for decades, we've gone so far down the road of billing for services that aren't really covered by the policy. We can't even understand what the policy is supposed to be.
I agree with that. We've talked about it before. Across the entire country, people are billing Medicare, therapists, practice owners billing Medicare when their goal is like, I want to be able to walk like a mile, and it's already beyond medical necessity. And clinics all over the country are billing Medicare. That's why there's all these cuts, by the way, because they know that there's overutilization. But in terms of the situation between in-person versus digital, are you Tony, let's say we got 1 million patients that go to brick and mortar clinics across the country, 1 million people. Then we got another 1 million people that do telehealth only, where Julia, they don't even see them do the movements. Jimmy, which population gets better? Which population has better function at 6 weeks or 6 months or whatever? Which one gets results better in terms of getting back to their ADLs, their activities of daily living, sleeping better, moving better? Which one, in your opinion, do you think gets better faster?
I'm going to stay in the middle. I'm going to say whichever one does it the most. Whichever one does it.
Come on. So Tony, which group do you think gets better? Is it the digital? Is it equal?
What I would say is whatever one does it the most. I think now because we're changing culture. I still think it's the one in person right now.
Yes, it is. It's the one that has the most accountability. The one that has the most accountability, where someone has to put on their calendar, I'm going to Total Therapy Solutions, and Tony sometimes watches me. Sometimes he's making too many YouTube videos, and he's running around the clinic and he's answering phones and all that. That group will absolutely get better. And Medicare is like, hey, great, because we're paying for these Medicare beneficiaries.
You had me right to the last sentence. I totally agree. That group will get better.
I agree.
Right? That group will get
Faster.
better. How
Faster.
much better and how much faster, those are, to be discussed. But that is not what Medicare pays me to do, period. Right. Medicare does not pay me to sit there and make you get better. I've got a patient who can't get up from a chair. I evaluate that patient. I make the determination that, yes, with the appropriate exercise dosing and exercise selection, they can get out of a chair. Medicare pays me to evaluate them, to make the determination that this is what they need to do, and show them what to do. Medicare does not pay me to get them to get out of the chair, to work with them until they're capable of getting out of the chair. It's only to evaluate, to prescribe, to show them what to do. If I determine they don't have now this is in the Medicare literature, if I determine they don't have the cognitive ability to understand how to do what needs to be done, they're finished, they're discharged. I am not treating them anymore because Medicare says it is no longer a covered benefit. Just because I realize that they cannot do it on their own and they don't have people around to help them do it, we're finished. So yeah, they'll get better. But that's not what Medicare is paying me to do. If they pay me like your situation, then absolutely, man, all day long, 5 days a week, like let's make people healthy. I want to go down that road, but I'm in a third-party payer system. I'm going to do what the payer is telling me to do.
Okay. I was talking way less about the payer and Medicare. I'm talking about in-person versus digital. I'm talking about my practice and your practice versus Sword Health and digital. I don't really care what Medicare talks about because we don't take it. I don't even have to know it. Thank goodness. You post these things. I don't even look at them, the Medicare post, because I don't even have to worry about it. And yes, I've said we agree that everyone overbills Medicare because people walk in and they're able to, play weekend softball and they have, you bill their Medicare, you meaning the clinics across the country. I'm talking about in-person, either in an office like yours or home visit like us. I'm talking about in-person versus Sword Health, in-person versus digital. That's what I was talking about. You take 1 million people that do in-person physical therapy in some form or fashion. You take another 1 million people that do digital. They do Hinge Health. They do Sword. They're doing movements with sensors and it's not even reading it properly. And they're doing movements and then they're logging in like what they did or whatever. And this therapist is tracking 500 members. There's no comparison which group gets better. It's in person. And listen, by the way, you guys know me very well. If digital was better, if that was more profitable, if it got better outcomes, all that, I would be in that business. Okay. You know this.
Now, here's my take is as soon as this came on, and I feel like the Hinges and Swords, I don't have their Wikipedia page up in their history, but this is within a year and a half, right? I'm not saying the companies aren't older to get to this point. And like Tony, I think you had even said, this is the first shot across the bow. Like there's no way this is going to be the way 3 years from now or 5 years from now. It will be like every other thing. This is where I get to sound like a genius just because this is why we study history. It's not going to be Sword or that delivery. And it's not going to be fully in person though. There will be elements of both. And it'll be what the customer is demanding, what the payer is willing to pay, and what we can prove works. It'll be this amalgamation of all these different things.
I mean, look, now I passed that generation. I am not in this world, but my understanding is a lot of people are meeting wives and husbands and, on social media. They're meeting through apps. They're meeting through all of these matchmaking electronic platforms. Yes, there's still an in-person component.
Yeah.
But the idea is if you would have come to us 30 years ago and you would have been like, look, you're going to find your wife or husband through an app, people would have been shocked. They would have said, no way, never in a million years.
Here's the thing. In the beginning, like this was a thing like so built into culture in movies and TV shows where the husband and wife are meeting the friends or the parents for the first time at Christmas. And they'd go like, hey, how we met is going to come up. We met, let's get our story straight, because everybody was so embarrassed of meeting online. And now it's like, dude, swipe right is ubiquitous. Like it's everywhere, right? Swipe right means I like you. It's like, oh, that's totally normal. So I think there's pendulums It's not a pinwheel though. It's a pendulum. It goes from everything's in person to like, oh, this digital thing is here. It's going to take over. I'm like, it's new. It's shiny right now. It's going to pendulum back the other way. I'm looking at this now. Let's take this like in a different direction. I work with other organizations, APTA organizations, the AAMS of the world. I'm looking at 2020 to 2025. And here's the pendulum I see to give you an example. Everything was a virtual conference in 2020, 2021, 2022, right? Everything went digital. Everything was an online everything, courses, the whole nine. I'm predicting, and where I'd like to skate, maybe we could do something together. I say if you start offering people in-person experiences, there's a couple organizations that do this well. Jet Set Rehab, I think, is one of them. They're like, hey, you want to learn shoulder from this shoulder expert? Great. We're going to Aruba. And we're going to do 7 days in Aruba. The course is 3 days, which means you got 4. So you're getting to use Con Ed money to fly to Aruba to do the Con Ed, like a portion of it. So what I'm getting at is I think the pendulum swings back. You don't need to be a genius to figure this out. If everything swung towards digital and people are sort of it's like they're just eating too much vanilla ice cream, they're going to want chocolate, and chocolate's in the other direction. So if it's digital, it'll swing back. But the answer is definitely a mix, something in the middle. Go ahead.
Maybe Tony proved my point. The whole dating, social media, two people get connected. They're in some, they're in some Facebook group or whatever. They get connected digitally. They start talking digitally, texting on the platform. They start texting or emailing off the platform, but still digitally. But then it moves to in person. And the only way for that whole arrangement to then get closer is to do the in-person, like Jimmy said, in-person experiences. You go on dates, you go to the movies, you get popcorn, you go walk on the beach, you do all the things in person. That proves my point. Yes, I agree, Jimmy. There might be a compromise in the middle where in 3, 4, 5, whatever years, maybe there's some digital stuff, maybe there's some in-person stuff, but there's absolutely no way that it'll be full 100% telehealth virtual care for physical therapy. Tony said it also before on the platform, on the show. Telehealth is great for like triaging and, communication and coaching and potentially early diagnosing and using the physical therapist's brain. But then also some of the treatment needs to get done in person, and the accountability and the in-person assessment. So I would say it's a little less about a pendulum, though. I think it's maybe some virtual, maybe some in-person, but there's no way these companies are going to be around in 10 years.
See, you agree with me. See, you agree with me. So
no, I agree with your premise of two people find each other on social media. They start talking. Tony, did they ever end up married with kids without ever meeting in person? No, it's impossible.
I don't know.
Very difficult.
All right, the bariatric PT, which I don't know who you are. Let me know who you are.
That's Christine Corgenet.
Oh, okay.
She took my advice. I threatened her. I think I talked about this.
Yeah,
I did offline, and I said, "What do you want to do?" And she's like, I think her name was like PT in your pocket or something. And I was like, "But what do you want to be?" And she said, "The bariatric PT." So I pulled a Tony move, and I went to like Squarespace. I looked up the bariatricpt.com, and I said, "I'm buying the bariatricpt.com domain name for $14 in 24 hours, and I'll sell it to you for $1,000." So it looks like she went and bought it. So good on you.
Which I remember now, but I forgot. I love the bariatric PT. I mean,
we need a better logo.
Talk about that tonight in my marketing course because that's
good luck.
Hold on. We need a better logo, Christine. Here's why. It's so small on the screen. Look at that thumbnail. I want it bigger. I want less there and bigger in your face. But here's her question. She's asking what, Tony?
If I missed it, how is she billing for services through Sword? I would imagine it's just like an employer funded, these employers are self-funding their healthcare stuff. So the employer is just paying for it. I don't know. What are your thoughts?
So, yeah, I mean, probably billing their plans though. Wouldn't they still have to bill the in-network plans? Just like if it was in an outpatient physical therapy office, how would that be any different?
You're saying they might Hinge these. I thought they were advertising these or promote. Someone correct us or someone give us. Maybe Julia's still watching. I thought it was like an added benefit for these self-funded plans where it was like, hey, we offered it. It reduces cost. And again, now you have a Julia handling like 500, 600, 700 people. There's that math game. Seth Peterson, if you guys know Seth Peterson, he's out in Arizona, I think. He won an award for this like innovative practice model. He's like, I just use telehealth for triage. Like I was saving people ER visits. Like he's like, he's sitting in his brick and mortar clinic saying like, I still think this is the end game, but he's like, we were able to processize this triage thing.
Yeah, my understanding, and we have a couple of big local employers. They have self-funded
Julia's still
healthcare.
here.
It's managed through like United Healthcare or Anthem, but they are paying for all of it internally. And so they would hire or pay Sword or Hinge or any of these places to deliver this service, because if it does reduce the, workers going out to orthopedics, they're going to see that on the back end.
Yeah, there's a nod to, does it work? Is like, these people hate spending money because it's their money. The less money they spend, they keep it. Julia's jumping and saying it's an added employee benefit. It's also early. Like, who knows if it saves money like in 10 years? I don't know.
So, Julia, I'm curious, are you guys billing via CPT codes, or is it just like, hey, I completed like an interaction, or I did an interaction with, patient number 501? Like, how does that work? She might not know the back end on the payments. I don't know.
Or are they just getting paid per patient, whether they use it or not? Like I want to be in that business model, right? Like that's the insurance company. Hey, you pay me, and if you use it,
then of course we want 1,000 of your patients, and we have one therapist to manage 1,000 patients. Yeah, of course.
Yeah.
We were going to talk about something else. What were we had it on the agenda, and I can't remember now.
We need an assistant or an intern.
Intern, free volunteer intern. That is what we need.
We need one intern for the next 500 topics.
no CPT codes. Oops, sorry, Jimmy. Go ahead.
No CPT codes, just based on how many times. So it is per episode. So how many times the patients were completing sessions. And then what's a session? Was a session like this is like perfect for the next generation, because she was like, I was having chat conversation. Julia was doing PT in the DMs.
So hold on. The company is going to pay Sword Health for more of the completed sessions. The completed sessions, she said, it could be something like 10 squats. So now the more that the employee exercises, the more the company has to pay. The company's alignment in incentives are not aligned with the patient, the employee. Does that make sense or no?
It depends on how deep you go, because the theory is, and this has always been my problem, like I hate worker like wellness programs and stuff like that, because like you said, if I'm the employer, I'm sitting here, I'm like, I'm wasting all this money. You have to be able to show on the back end, okay, the more the employee exercises, logs in, uses it, the lower my payments for surgeries and medication and imaging and all the other stuff. I treat an individual who manages benefits for a large local employer, and she sees these numbers. Like, she can tell me how many times their employees are getting surgeries, how many workers' comp claims they're having, all of this kind of stuff. And they're big numbers.
This is the crux of our profession, what Julie is saying. It's like the theory is if patients do more exercise, they prevent injuries. This is the thing on the intro to PT school, which is if you do what we say and what we know, we stop the down. This is ultimate upstream. So again, I don't think it's going to be everything, but isn't that the idea? It's ultimate upstream.
To me, what's so amazing about this is you have real objective data. At least you can see when the patient is logging in, when the patient is complying with the medical, prescription. In my physical therapy clinic, guess what? I can prescribe the best home exercise program in the world. I have no tracking system. I have no way to know if the person's actually doing it or not. Where in Julia's case, like, there is some level of objective data coming back in and say, look, at least the person did log in, and we track some sort of objective metric.
Dave's getting a call from the president.
Plumber, broken pipe that was rusted out. And I wish there was like a telehealth, like virtual service, but they need to come in person. It's just the way it is in the world that we live in.
Although, how great it would be like to FaceTime with someone and be like, let me see what I've got here. What are we looking at? I do that with my buddies all the time. I walk them through my basement and go, what do I need here? What do I need? Oh, I'll make sure I bring that. And I bring that. So again, I shared
this on the show. A neighbor of mine owns like a multi-million-dollar plumbing company. He is not a plumber in any way. I was like, why don't you guys offer virtual consults? I can do enough plumbing to, fix basic things. I'm like, I would love to get a plumber. I'll pay $60 for 10 minutes. Look at this. Tell me what I need to do. Give me the tools, give me the recommendations, and then I will do it. I mean, that's exactly, you know, as a therapist, assess my shoulder. This is what you need to do. Okay, now let's bring in the personal trainer. Let's bring in the, you know, aid to actually do the things with you. You don't need me to do the thing. You don't need me to lift the heavy object. Let's just get somebody else to do it.
Jared, agreeing with you. Even if computer vision is not perfectly accurate for range of motion, which I'm going to be doing an episode with Holly. It looks like Haley. It's spelled H-A. She was commenting on some of your stuff yesterday.
Oh yeah.
She's with Vi 5. And it's like this, it creates a wireframe out of a human being, and they measure like range of motion and movement and stuff like that. But even if computer vision is not perfectly accurate for range of motion, at least it serves as a rep counter and an accountability tool.
Man, I thought Jared was on my side, but
there's no sides here, guys.
How is computer vision an accountability tool?
Look, Scott did a FaceTime with a friend that diagnosed his AC. Is it AC joint or air conditioning? I'm going to guess it's air conditioning issue.
But you know what? To Dave's point, like I'm in my clinic right now. There's probably 6 people out there. They're not doing it virtually. They're doing it in person. They're telling jokes. They're cracking up. They're having a good time. I'm trying to mute myself so you guys don't hear all of it. But there is always going to be a place for in person.
Jared straddles sides. He is not a party affiliated. He is issue oriented. Haley will be on the show pretty soon. I encouraged her. I said to her, I was like, look, you have a wireframe app in Vi 5. I jumped on for 15 minutes. I was like, that was dope. I'm like, you have a very visual product. Why can I not see the visuals? And it's the same thing. Like when I talk about stuff that I'm doing with Vestibular First with you guys on and off the show, you guys are like, how come you're not doing this? I'm like, yeah, we need to. And I'm like, yeah, okay. Like we sell infrared video goggles. I'm like, and this has been in the works too for a while. I just convinced someone internally. I'm like, we need to be I want you know what night vision goggles look like? They have that sort of like black and white, maybe like a little greenish, bluish tint. I'm like, we need 5 of those a week. If we can't say we're that thing, we need to show that we're in show business. We need to show. And it also doesn't need to be perfect. I want to go back just in case anybody from my job was watching before I get work in a minute. Just in case anybody from Vestibular First is watching, it's like we in show business, baby. And I don't want to tell people how great the product is. I want to punch them in the nose with it every day.
I will say something that's interesting. I know Julia said that. I was listening to Peter Diamandis, I think is his name. He's got a YouTube channel and he's always talking about futuristic stuff. This was like 2 years ago. This isn't anything recent, but he said even back then, they were at the point with VR in certain VC funded, programs. You could put on a glove, you could reach to something, a physical object, and the glove would give you the sensation of touching that physical object, even though there was nothing actually there in space. So I could see a world where Dave is saying, okay, now Dave didn't say this, but we know we've got declining population. I want to do an episode where we talk about how we build a physical therapy business for the future where populations are declining. I want to talk about that. But a world where there's somebody somewhere else in the world that has the technology on their end, I have it on my end. VR is to the point where it looks like you're sitting in the room next to me. You're not pixelated. You're not on latency delays. And I can put on a glove and I could touch your shoulder. I could rub your butt, like we always say, and I could feel it in my fingers at the same time that you feel it on your skin. Even though we're 1,000 miles apart, I think that world will exist.
We're in the last 10 minutes of the show, and I'm debating whether or not I go R-rated or stay PG-rated with this. Screw it. Let's go.
Porn drives everything. I've
Correct.
also heard
you knew exactly where I was going with that.
They are the innovators in all of this technology. There's no reason to cover it up. No kids are watching. They are leading the way in this kind of stuff.
And here's what I was going to say. Like you guys heard, and some of the kids out there are not going to know what either of these platforms are, but there was a choice that Hollywood had to make in the, 70s or 80s about VHS versus Betamax. And Betamax, if you're like, I don't know what Betamax is, there's a reason for it. It was a superior technology. It had better, visual, better audio, whatever, when you had movies at home. But the reason we went with VHS is somebody dropped off bags of money at adult movie facilities, and they were like, we're going to go in this direction, and we're that direction, the most human connection business, or lack of human connection business. But my point is, and you knew exactly where I was going, so maybe I'm not as innovative as I thought. If it shows up there, it'll show up in PT clinics a year and a half later. It hasn't shown up there. I mean, I haven't done a ton of research on haptics and adult alone time. My guess is it's coming in more ways than one.
Hey,
Tony left. He's like, I'm out. I'm out.
All right. For the record, my family did have a beta version of VCR. It was beta before we went to VHS. I think we also had an 8-track cassette player. We had a CB radio. Like, there were so many things back in the day. I love seeing those Facebook memes and pictures of like kids' toys that I actually had, like the roll of caps, and it says you can smell this photo.
Oh, I can smell that. Yeah.
All of that stuff. Like, I love all of that stuff.
I saw a great post. This will tie in with what we do. Someone shared, there should be some sort of technology where we could all listen to a podcast at the same time if there's breaking news. And someone below was like, radio. You just invented radio. Like, everything's a pendulum, people. That's live streaming, right? It's the same stuff, different day. All right. We don't have enough time to start another topic. We'll get our intern. Just email one of us if you want to be our intern.
Send your applications.
And that job title looks like keeping us relatively on track. Just keeping notes. You'll get, this is what I used to do in radio, write bad job descriptions or bad solicitations. No pay, horrible, well, unlimited hours, like, work whenever you want. We're live twice a week, and you get to see behind the scenes at my proof of life, so you get to hang out with us when we're not broadcasting. So we want to do parting shots or what?
Well, real quick, let's do parting shots. This one will be a little bit longer. Talking about ways to make connections, the right way and the wrong way. When somebody reaches out through LinkedIn to me, the first thing I do is I look for the credentials after their name. If they're not a PT, or PTOTSLP, I almost always ignore it. But Haley Jones, I never saw your name. I never heard of this person. I have no connection to this person. She left such an interesting comment on one of my videos that I screenshotted it and I sent it to you guys last night.
Yeah.
And I said, look, this was such an impactful comment. Now, instantly, when you said Haley Jones today, I knew exactly who you were talking about. She didn't message me. We didn't connect. Outside of that, she just left a really good kind of impactful comment, and it stuck in my head. You guys, we need connections. We're in a networking world. We need to know, different people. Reach out, make those organic connections. Even if you can't touch them in person, you can connect with them virtually. I think that's going to do more to move your business forward than just about anything else that you could do. Dave, what you got?
Well, you said Haley Jones. She's a PT. It's the screenshot you sent says PTDPT.
Yeah.
Oh, I thought you were saying she wasn't.
No. She is. I had just had no connection to her prior to that.
Got it.
But that was the best way to make a cold connection. Not that she was even trying. I'm just saying that was such a good way to make a cold connection to me, better than trying to direct message me and, sell me something.
All right. Parting shot. So with the virtual stuff, but let's put them in two buckets. We have the employee wellness. It's an added benefit for all the employees of whichever large company, and it's typically free. And this is like, hey, do 10 squats, do this, do that. And these employees might be healthy. They may not really have any major musculoskeletal orthopedic issue, right? Like, that's one bucket. Then the other bucket is employees of these companies who actually have carpal tunnel, sciatica, migraine headaches, a stiff knee where they're limping and they can't walk. They have plantar fasciitis, different things like that orthopedically that are somewhere between medium to moderately complex. The first bucket, yes, it can help those people virtually. This whole virtual thing, Sword Health, Hinge Health, whatever. When someone has these orthopedic issues, carpal tunnel, sciatica, radicular symptoms, persistent low back pain, all this type of thing, Achilles tendonitis, tendinopathy, that type of stuff. This is where virtual will never solve or help most of that population, in my opinion. So that's my parting shot.
Yeah. I would piggyback on a statistic I heard years ago, which was most mid-sized companies under communicate by a factor of 400%. What they were talking about was internal communications. Like if you were going to try to get culture change at your organization, we send an email. It's on our internal social network, things like that. We brought it up in meetings. You're still, even when you've exhausted everything, you're still under communicating by a factor of 400% to reach that culture change or to actually get someone to know something. Never mind if they actually do it. Your job is to get them to understand. Their job is to hopefully eventually do it. So I think the idea here is, I want to piggyback off of what Tony was saying, which is say it more, do it more, 100 times more. And if you think that you've done it, you're still 300 times under doing it in terms of reaching that culture change. So share more, do it ugly. I mean, do you think this is what I walk around in public in? No, but I woke up late because I had a beer league hockey game until 1 a.m. So I'm rolling out of bed a little beat up this morning, moving a little slow. So communicate more, do more. I actually just saw Sword Health for the first time now putting up Instagram reels. And I'm like, really? $1 billion company, whatever they are, and now they're just putting up Instagram reels. Cool. Hey, well, thanks for coming to the party. We'll be back on Tuesday. What are you guys doing this weekend? Give me something good that you guys are doing. I need motivation for the weekend. Anything? Tony's like, no, I'm not doing anything good.
We're going to be doing kid stuff all weekend. Basketball tournaments, shows, theater. That's it.
Good. Take care of that.
Nothing crazy for me.
Perfect. All right, gentlemen, have a great weekend, and we'll see you back on Tuesday.
The PT Pinecast is a product of PT Pinecast LLC. It is hosted and produced by PT Pinecast CEO Jim McKay and CBO Sky Donovan from Marymount University. We talk PT, drink beer, and record it. This has been another pour from the PT Pinecast. The PT Pinecast is intended for educational purposes only. No clinical decision-making should be based solely on one source. While care is taken to ensure accuracy, factual errors can be present. More on the show at ptpinecast.com.
Listen, if you're running a PT practice and you're still using old school systems, you're leaving time and you're leaving money on the table. Empower EMR is here to change that. It's an all-in-one, automated and built to streamline your scheduling, billing, and everything else so you can focus on what you do best, helping patients. Don't overthink it. Go to empoweremr.com. That's empoweremr.com. Book a demo and stop letting outdated tech hold you back. All right, PTs, if you're serious about crushing the OCS exam or leveling up your clinical game, Current Concepts of Orthopedic Physical Therapy, 5th edition, is where it's at. This is your one-stop shop for the latest in ortho PT, with expert insights on every joint, real-world case scenarios, and evidence-backed techniques. Don't sleep on this. Go to orthopt.org right now and get a sneak peek and start prepping like a pro. That's orthopt.org. One more time, orthopt.org. Go there.